Revising once again the brachial plexus and the nerves that emerge from it, because you have to revise it again and again to remember it by heart. 5, 6, 7, 8, 1. 5, 6 forming the upper trunk, the 7 forming the middle trunk, the 8, 1 forming the lower trunk, dividing into anterior division of these two forming the lateral cord, posterior division of all cords forming the posterior cord, and here you have the medial cord continuing as the musculocutaneous, radial, ulnar, and median. The lateral and the medial cord contribute the median. We've covered the musculocutaneous nerve, arises from the lateral cord, pierces the coracobrachialis, lies between biceps and brachialis, then between brachialis and brachioradialis, pierces the deep fascia, becomes the cutaneous nerve of 4R. Then we've covered the ulnar nerve arising from the medial cord, continuing till the middle of the arm, medial to the artery, piercing the medial intermuscular septum, lying in the canal of Cannon, then between the flexor carpi ulnaris and flexor digitorum profundus, supplying the flexor carpi ulnaris and the third and fourth component of the flexor digitorum profundus. 5 centimeters above the wrist gives the palmar carpal branch, supplying the palmaris brevis and the hypothenar eminence. Passes medial to the pisiform, divides into the superficial and deep branch. The superficial branch supplies 1.5 fingers, communicates with the superficial branch of median. The deep branch passes between abductor and flexor digiti minimi, pierces the opponents, supplies third, fourth lumbrical, all interossei, and ends in the transverse head of adductor pollicis. So this is the ulnar nerve, and you have to remember it like this. Then the median nerve arises from both the lateral and the medial cord. Arises from both the lateral and the medial cord, lies on the lateral side of the artery, in the middle of the forearm, middle of the arm, crosses medial to it. Then this is the artery, divides into ulnar and radial. The nerve is on the medial side, it crosses like this and is separated from the nerve. The structure that separates the artery and the nerve is the ulnar head of pronator teres. So this is the humeral head and this is the ulnar head. So the humeral head lies between the humeral and the ulnar head of pronator teres, separated from the ulnar artery by the ulnar head of pronator teres. Then it passes between the flexor digitorum superficialis heads, lying on the interosseous membrane, accompanied by the median artery, bounded by the profundus on the medial side and the pollicis longus on the lateral side, then crosses the pronator quadratus, lies in the carpal tunnel. Lies in the carpal tunnel. Divides into superficial and deep branches. Superficial supplies 3.5 fingers and communicates with the ulnar, superficial branch of ulnar nerve. The deep passes between abductor and flexor pollicis brevis, pierces the opponents and supplies the lumbrical 1 and 2. So this was the median nerve, and now we will go on to the radial nerve. The posterior cord. For posterior cord, we will make again the scapula, the glenoid cavity, the supraglenoid tubercle, the coracoid process, the suprascapular notch, the superior border, the medial border, the head of the humerus, the greater tuberosity and the shaft, we'll make this straighter, the bicipital groove, the lesser tuberosity, then we'll place the labrum, we'll place the capsule, then we'll place the subscapularis muscle attached to the lesser tuberosity, the teres minor going behind the capsule and getting attached here. The other structures are supraspinatus and infraspinatus, the sit structures. Then the teres major getting attached to the medial tuberosity. The long head of triceps, arising from the infraglenoid tubercle, passing anterior to the teres minor and posterior to the teres major, forming the quadrangular space, this one, the lateral triangular space, this one, and now we are in a position to place the groove on the posterior side of the humerus, posterior surface of the humerus, into which the radial nerve will go. So here is the posterior cord, posterior because it's posterior to the artery. Posterior cord has given an upper subscapular, a lower subscapular, and thirdly a nerve going to the latissimus dorsi. Latissimus dorsi is coming from behind and getting inserted into the between the two majors, the lady between the two majors, the latissimus dorsi. So you have given the upper subscapular, lower subscapular, and nerve to latissimus dorsi. Then the ulnar nerve, the radial nerve will be going to the lateral triangular space and will come to lie in the radial groove. will pass through this lateral triangular space bounded by long head of triceps, latissimus dorsi and inferior border of teres major and shaft of humerus. Then there will be an axillary nerve which will go through this quadrangular space, wind round the upper end of humerus, supply the teres minor and the deltoid coming from the acromion process getting inserted into the deltoid tuberosity here. So this nerve, axillary nerve, passes through the quadrangular space, supplies the teres minor, supplies the deltoid, and supplies an area of the skin which is called as the regiment batch area. So in the radial groove, the origin above and lateral to the radial groove is of the lateral head of triceps, long head infraglenoid tubercle, lateral head above this and medial head below this. And here the nerve is accompanied by the profunda brachii artery. Then the nerve pierces this is the lateral intermuscular septum. So the nerve winds round this and the nerve winds round pierces this lateral intermuscular septum, comes to lie between brachialis. Now on the anterior side you will have the brachialis muscle and the biceps muscle. And on the lateral side you will have the brachioradialis. So it lies between the brachialis and brachioradialis. The other nerve lying anterior to it is the musculocutaneous nerve. So this groove between the brachialis and the brachioradialis, brachialis on this side, this is brachialis and this is brachioradialis. On this side houses two nerves, the radial nerve and the musculocutaneous nerve. The radial nerve winds round the shaft of humerus and the musculocutaneous is coming from between the biceps and the brachialis muscle. So two nerves, radial and musculocutaneous, lie in this very important groove between the brachioradialis and brachialis. The musculocutaneous pierces the deep fascia, becomes the lateral cutaneous nerve of forearm. The radial nerve crosses the elbow. So here is the trochlea, here is the capitulum, and here is the shaft of humerus. Here is the ulna. Here is the radius. And this is the radial tuberosity. From the radial tuberosity you have the supinator crest. He told you that there is a muscle which arises from the posterior part of the medial epicondyle and also the upper 1/4 of posterior border of ulna. And this muscle we have come from behind, winds round the radius and becomes the supinator. So it has a humeral head, which is the superficial part of supinator, and a ulnar head, which is the deep part of the supinator muscle. So this is the supinator. On this side from the supinator crest would be arising the flexor digitorum superficialis, radial head, and flexor pollicis longus. I hope you can understand this. And what the radial nerve does, that it is lying between the brachioradialis and the brachialis. This is the brachialis muscle. So it's lying between the brachioradialis, which is originating from here, and going to the radial styloid, and the nerve crosses the elbow, divides into a superficial and a deep branch. The superficial branch continues on the supinator crest, lying lateral to the radial artery, and the deep branch passes between the two heads of the supinator, supplying the all extensors of the wrist. So there is a wrist drop, extensors of the MP joints. So there is a finger drop, and extensor and abductor of the pollex, abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus. So the thumb, so there is a thumb drop. It supplies the supinator, it supplies the brachioradialis, and it supplies the extensors of the wrist, which is extensor carpi radialis longus, extensor carpi radialis brevis, extensor carpi ulnaris, supplies the MP joints, extensors, which are extensor indicis, extensor digitorum, extensor digiti minimi, and then the thumb, the extensor abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, and therefore there is a wrist drop, a finger drop, and a thumb drop in paralysis of the radial nerve. If the paralysis is at the neck of the radius, then brachioradialis and extensor carpi radialis is saved, and therefore there is only a finger and a thumb drop. So low paralysis, finger and thumb drop. High paralysis, wrist drop too. The treatment, the diagnosis is fairly simple: finger drop, thumb drop, wrist drop. In the radial groove, a wrong injection can cause paralysis. Secondly, if there is a pressure for a prolonged period of time because a person is lying on the edge of the table after having a good drink, that is called as Saturday night paralysis. Or if you are excising the head of the radius, in fracture head of radius, then you can cause a low radial nerve palsy. So what do? You wait for recovery, and you can give what is called as a dynamic cock-up splint. So what this does is that if this is the hand, the splint would keep this flexed up to the wrist dorsiflexed, there will be a component of the splint like this, and from this component the fingers, you can put slings around these fingers which will keep the MP joint and the thumb flexed too. So this is a dynamic cock-up splint. It prevents contracture. And then for dorsiflexor of wrist, you can transfer the pronator teres, because it's in pronation that the wrist dorsiflexes. You can see that if you pronate as if you are trying to hold the pen, then the wrist will dorsiflex in pronation. So pronator and extensor carpi radialis longus and brevis are synphasic muscles. They act in the same phase. So pronator teres for dorsiflexors of wrist. Then MP joint is extended in the opening phase of grasp. When you are trying to hold, you try to increase the thing, and then you see that you have palmar flex the wrist. So palmar flexion of wrist is associated with extension of MP joints. So palmar flexor is palmaris longus and flexor carpi ulnaris. So flexor carpi ulnaris, two extensors of wrist, extensor digitorum. You ignore the indices and digiti minimi. Then for the thumb, you use the palmaris longus. So this is the Jones transfer for radial nerve palsy. Pronator teres to extensor carpi radialis longus. Palmaris longus to extensor pollicis longus, and flexor carpi ulnaris to extensor digitorum longus. This is the Jones transfer for radial nerve palsy.